Hi, one of the biggest questions that I get from veterinarians is in extraction sites, should we be using bone grafts? So take a look at the short segment and let me know what you think. This is a case that's in canine dentistry. I know you guys are familiar with this that have seen that presentation recently. This is an older case that we did, but it's a good example of bone grafting and a very common area that we do bone grafting. Back between that first molar and second molar, right in that space where we've got the capacity to accumulate plaque on those occlusal surfaces much more readily than we do in other areas of the teeth which have conical occlusal or conical surfaces that are non-occlusal. So looking at that radiographically, you've got that defect back there adjacent to the distal aspect of the distal root on that first molar, which is a significant area. You've also certainly got the bone changes on that second molar. The second molar is dispensable, so we would definitely want to extract that because that's part of the reason why that defect's there, obviously, and it's not a highly functional tooth. So extracting that certainly eliminates the potential for that lesion to occur again. If we leave it, then it's very likely going to occur again, so we want to get that out of there. Even if it's a minor defect. I mean, this one's got some major things going on. You see the increased periodontal ligament space around that distal root. You've got probably a periapical lesion on the mesial root, so we'd want to get rid of that. And again, even if it's not that bad, we want to extract that. And that also accomplishes exposing that area better so we can see down in there and clean that defect much more readily. So extracting that and using your periodontal curette to get down into that bone and look at that. You can see that marginal bone level there, and then you can see it there superimposed over the root. And then you can see down into and apical to that marginal bone where we need to clean. So we've just extracted that tooth, we've extended that flap rostral so that we can expose all that around that root. And so we'll clean all that all the way around, make sure that there's no granulation tissue down in there using our curettes. And another thing that I use that I don't know a lot of you realize or that we've talked about before, but another thing that we use is a fine cylindrical diamond burr. If we've got enough room, which we would in this case, around that defect where we can get that cylindrical burr in without damaging the tooth, we'll take that cylindrical burr down in there and eliminate the fine granulation tissue that exists after we use our curette. So we go down in there with our curette and do the best we can and do that quickly and do that without really worrying too much about hemostasis. And then once we're at that point and it's more difficult to get the little segments out, then we'll take a cylindrical diamond, which is a little wider than your cross-cut tapered Fisher burr that you use, your 701L, a little wider in width. And it's also a little bit tapered to the tip, not much, but there's a slight taper from the base to the tip, and we use that in there, and that'll help considerably to get you to the point where you've really got that cleaned out really well. And then once that's done, you can use 17% EDTA solution to get out the dentin mud, if you will, all the little dentin shavings that occur when we clean that, because we're scraping the dentin, and when we scrape the dentin, we're scraping that material down into those tubules. So EDTA is a inorganic solvent, so it will remove those little particles by dissolution that are in the tubules, and we put that in there for 4 minutes, and then we rinse that out. And once we've done that, then we can go in and put our bone graft in after we've flushed that and dried that area. So with doing that process, we're going to have hemorrhage in that area. So we just literally just mix our bone graft with the hemorrhage there and form the graft with the blood. And this is consul, so that's one of our choices that we have for bone graft material. Obviously, a blood clot is a choice too. In this case, because we're wanting to maximize alveolar bone height, we want to get that bone height back up to the area where the marginal bone is now. We would want to use a bone graft versus a blood clot because, as you may remember, in a year's time, 1 to 2 millimeters of that marginal bone height will be compromised when we use just a blood clot. So in extraction sites, when there's no adjacent tooth, that's fine. But when we're working on a tooth like the one we just showed you, we want to make sure that we maximize that bone height and not lose that 1 to 2 millimeters, and so that's why we'd use a bone graft. Consul is an osteoconductive graft. It just forms a matrix for the osteoblasts to attach to, increases the surface area there for those to attach. And so there are no components in there that cause the bone to grow, as opposed to another graft that I'll show you in a minute, which is osteoinductive, that does have components that will help the bone to grow. So that is before, and then that's after. And if you guys remember this case, this was a Spitz that was in my general practice maybe, I don't know, 20 years ago. And we were able to follow this guy out for 7 more years until she was euthanized for seizures, and we'd get her back every 6 months, and this is what it looked like. We certainly want to follow the periapical area to make sure that we didn't have any endodontic disease. It just wasn't showing up radiographically yet. So every time we get this patient back for at least a year or two, we're going to pay more attention to that to make sure that there's no changes there that would suggest a problem. And this guy obviously did fine for that period of time. So opinions vary in veterinary dentistry on this topic. We'd love to hear your thoughts, so please leave a comment below.